I get knocked down, but I get up again.
It's procrastination. It's purely procrastination. Cool. Welcome to Ross. Thank you.
Boy, oh boy. Okay, so you guys have used 14 minutes of my 20 minutes, so I'm going to cut this down to 6. Is that okay? Right. Hi, guys. My name is Ross, and I'm an wrong meeting. I'm an anaesthetist, which is nearly as bad. And so it might be a bit odd as to why I'm standing here addressing an emergency medicine fraternity, but, well, this is kind of my spiritual home as what I like to call an acute phase critical care physician. And I hope that describes most of the people in the room. And I hope that a lot of the things that I will say will ring true with you, even though my main work these days is earning money by pushing drugs to children and little old ladies. So you will notice I don't got no slides because I want you guys to listen to what I'm saying and I want you to use your imaginations a little bit. So while almost all of my talks to date, and Kat will back me up on this, have been based purely on drama and really fancy-looking slides distracting you from the content, I'm going to go out on a limb here and I'm going to try and address you with the content in the absence of the slides. Here goes. Right, first things first, I'm an anaesthetist, so could you please all close your eyes, sit back in your chairs, take some open your eyes. Pick up the red cards and the green cards, right and left hand. Make sure you know which one is in which hand. Let's have a consensus. So red is in the right hand, Ross. Okay, red in the right hand. Okay, now you all know which hand it's in. You can close your eyes again. Sit back in your chairs. Take nice, deep breaths in and out. In and... You're not closing your eyes. I'm serious about this. Just breathe deeply, and I promise this will all be over soon. You'll hardly feel a thing. Right, all your eyes closed. Okay, here comes a moment for some honesty. I'd like you guys to think for a moment. And this is going to take just a little bit of guts. I'd like to know from you, by raising the red card in the air, if you can think of a time in your career, it just can be once. Your career can be quite short. I want you to raise the red card up in the air if you can think of a time when you made a mistake, an error, an omission that could have led to a patient being harmed or that you know led to a patient being harmed. Right? Think that through. Okay? And if you can think of a time when you think you might have harmed a patient in your career, raise that red card high in the air. Come on, people, stretch to the sky. Right. Now, hold that red card high in the air and open your eyes. What the hell is wrong with you people? I'm sorry, have I come to the wrong place? Is this badEM? Is this the best, most motivated, most learned emergency medicine practitioners in the country who are sitting in this room on a nice Saturday afternoon when they could have been at Steenberg drinking wine? Is this the right room? And yet all of you have made errors that you thought you've harmed patients. Yeah. Yeah, this is the right room because all of us make mistakes. So here is the last thing I want to tell you in this talk. Mistakes are inevitable. We are going to make mistakes. We are humans. Humans make mistakes. Most of you make mistakes. Sorry, hold on a moment. Who in this room is going to be deeply offended by profanity? Right, okay, wrong room. Okay, if there's anybody I don't offend during this talk, I'm sorry, I'll get to you as soon as possible. So, we are humans. We are going to fuck up, right? Mistakes are inevitable. Learning from those mistakes takes a little bit of time and a little bit of effort. It takes ownership to learn from your mistakes. But they are great, great teachers. So, in the spirit of sharing, a colleague years ago, I entered a competition. There was a conference competition where you could enter as a registrar, and you could compete against other registrars from around the country as to who could give the best talk. It's awesome, hey, right? So it's like, it's like Smack before Smack was around. And you could talk about anything in anesthesia, you just had to give a great talk. So I went in there, I was guns blazing, I had this fantastic talk, I'd researched, I'd prepared everything, and I didn't win. I was a bit grumpy, and one of my colleagues beat me. And he was a bit of an ass, so it really hurt me to go and say to him, now I can't use his name, let's call him Jonty. So I went to him and it hurt, but I said to him, listen mate, you won, I didn't. I want to know, like what was it? Did you really prepare? Did you like study your material? Was it your kick-ass slides? And he said, I said, was it the fact that you wore a suit? Because he wore a suit, I didn't. Clearly not learned from that one. And he said, no, Ross, the trick to giving a really cracker talk is make sure you know more about the subject than anybody else in the room. Now, if you're not particularly smart, then you can't really do that on a normal topic. So pick something so esoteric that nobody else knows anything about it. All right? So I've picked a topic that nobody in this room knows more about than me. Not even my greatest fan, my Labrador. Not even my second greatest fan, who's my mother. I'm going to tell you about my mistakes. And I'm going to share stories with you now that will probably land me in jail if people knew about them. So are there any lawyers in this room? Right. So let me take you back a little way. Back to about a year or two ago, I was a brand new anesthetic consultant. I was fire and brimstone. I was great guns. And some of you might know I'm kind of into airways because, let's face it, airways are cool. I mean, fantastic. I was a consultant on call for the day at a district hospital. Let's not mention any names. Somerset. And I was there to anesthetize this list, and there were these patients, and everything was fanky-dory, and I went to go and see one of the little old duckies because she'd come in quite late. Oh, it was a sweet, like 89-year-old Indian auntie, oh, she was so lovely. And we had a lovely chat. I will offend everybody. And she was getting a vaginal hysterectomy. I said, that's fine. She had terrible lungs. She was one of those, 60, 70 pack-year smokers. She goes through 3 or 4 packs a day, her fingers with these lovely curling yellow talons. She was gleefully smoking, though. And she had horrendous COPD, and she had bronchiectasis, and, you could smell her halitosis from down the hall. I believe the technical medical term is that she had frot lungs. And there was no way that I wanted to give her a general anesthetic. So I was like, no, don't worry, I'm going to pop in a spinal, a little funky-dory, a little bit of sedation, you'll be happy, you'll just lie there, and it wasn't great. So she comes out to theatre, and I'm cocky as hell because, well, it's me. Plus I'm a brand new consultant. And there's an intern there, he's like, can I do the spinal, please? I'm like, yes, of course you can do the spinal, crack on. And he puts in the spinal, and I try and give him some pointers because, everyone's entitled to my opinion. And puts in the spinal, and she lies down, and they start prepping, and as the scrub nurse goes past her nether regions with a cold swab of iodine, she goes, ooh! And I'm like, ooh, that's spinal, So the surgeon's like, is there a problem? I'm like, no, of course there's no problem. Please, problem. Just carry on prepping, I'm sure the spinal will be working in a moment. And I'm twiddling knobs, and I'm twiddling the bed this way and that. I'm doing all the things that we do. And the surgeon goes with a nice cold speculum and puts it in, the patient goes, woo! And of course the spinal, and the spinal is perdida. She is Ayuko spinal. Spinal is out of stock. So I think, well, I'm going to have to salvage the situation now. So, they don't make me a consultant for nothing. So I grab the pump that's running the propofol sedation, I crank the dose up, she drifts off to sleep, and I go there and I'm ready to pop in an LMA, and I discovered that, she was having this lovely conversation with me yesterday. I forgot to open her mouth. Because she's got TMJ alkalosis, and she can get about 1.2 centimeters between her gums. What was the technical term that you just used? Oh shit, yes. And I realize I cannot get this Proseal LMA in my hand into this lady's mouth. Now I panic. Now I grab a laryngoscope and I try and get it in. I can't get the laryngoscope blade in. Her sats start going bloop, 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 bloop. The surgeon says, is there a problem? Like, no, of course not. Yes, there's a major problem. So I slap a face mask on her and I try and bag her. And I can't bag. And her saturations go bloop, 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 bloop. And she starts to become bradycardic. Bloop, bloop, bloop. How are you all feeling right now? You've opened your eyes again, but if you're imagining... So someone over there is giving me the international symbol for AF. Anal flutter. Yes. I had severe anal flutter. Stop laughing, this is very serious. Actually, this reminds me of another story. So, some time before that, I was a brand new senior registrar, and I was starting my senior pediatrics anesthesia rotation at Red Cross. And I was now, usually as a registrar, even if you're an SR, you still have a consultant who's watching over you. But we're a bit short-staffed that day, and one of the consultants said, look, we're a bit short-staffed. Ross, you've got an airway interest. There's a maxillofacial list, sorry, no, not maxillofacial, a plastics list with a kid with quite a severe cleft lip and palate. How would you feel about, you look after that, I'll send you a good intern. I'm like, of course I can do that. So off I go to my theatre, and it's a sweet little kid, 18-month-old kid, like, la, 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 la. He's about as big and as cute as my daughter now. And nice little child, friendly mum, and they come into theatre, and I'm like, yeah, it's all going to be fine, everything's going to be funky-dory, I'm going to do this, I'm going to do that, and a bit of local, bit of that. Giving my normal anaesthetist spiel. And I've worked out everything. Kid weighs about 8 kilos. We do a nice little gas induction. My good quality intern slips in an IV line, and I'm about to pop in the tube, but as I like to do, I want to get some analgesia on board early, and I pick up my syringe to give some back again, to give some fentanyl, and now I've been very careful. I've diluted 100 mics of fentanyl into a 10 ml syringe, and I know that I always like to give 1 mic per kilo, and I only ever dilute my morphine and my fentanyl into 10 ml syringes, and the morphine's a milligram per ml, the ketamine's, what were we talking about? And I must manage that airway. So I quickly work out 8 kilo child, that's 8 mls, and I give 8 mls of fentanyl, put the syringe down, and the nurse who's holding the bag says to me, that's funny, I can't really ventilate nicely now. And I go, no man, give me that. I can't ventilate. Child's chest is rigid. And the SATs, anyone want to give me a suggestion? What do they do? And in that moment I realize, as the child's becoming bradycardic, that I've confused my 10 milligrams of morphine and my 100 micrograms of fentanyl. I've just given this child 80 micrograms of fentanyl when I wanted to give 8 micrograms. I've given a massive overdose. I've got chest wall rigidity, and this child is about to die. Did I have anal flutter? No, I had like a full-blown ventral tachycardia. I wish I could tell you that about that one time that I gave a drug overdose. Unfortunately, it was not that one time. There was another time when I was working with somebody else. And I asked the intern to draw up the ketamine for an RSI for trauma, and she drew up the ketamine, and we gave the ketamine. At the end of the case, the patient wouldn't wake up, and I was like, oh, what's going on? Yes, scratch. I checked the oxygen, I checked this, checked the other thing. Finally, I walked past the bin, and I picked up the ampule of ketamine. I realized I thought she drew up the 10 milligram per mole ketamine. She drew up the 100 milligram. I gave the patient 1.6 grams. Hey, I can see you working out the street value. Stop. Actually, that reminds me of another story. So just when I started my time as a registrar in anesthesia, now I'd come from being trained at Geef Hospital under a fantastic boss there, and learned a lot of really cool things. And one of the things was that we really got quite proactive about doing nerve blocks, and I was very proud of the fact that I was quite a dab hand at doing an interscalene block and a vertical infraclavicular block, and I was ready for this upper limb surgery. So off I go to Grooteskeer, and I get the whole, well, now you're a small fish in a big pond kind of speech, and I'm like, don't worry, I've got this. And go to theatre, and it's a patient who's having some work done on one of his shoulders. He's had recurrent dislocations, and he's got all sorts of scar tissue. He's having scopes, and it doesn't really matter. And I go into theatre, and I've checked the consent. We're operating on the right shoulder, and so I'm like, right, so I'm going to want to start by getting an IV line up. Then we're going to do a block, and he's like, okay, cool beans. And I push we're working in a narrow little induction room, so I push the bed across so I can get to his arm, and I'm chatting to him, and I put up the drip, and then he's going to be in the beach chair position, so I decide he's got a bit of a history of hypertension, I want an arterial line, so I'm putting up the arterial line, and we're chatting, he's telling me about, no, he's had such trouble with his shoulders, and this shoulder's doing that, and then the other thing, and they've got out of joint, and this, and we carry on talking, and I draw up my block drugs, and I go there, and I've given him a little bit of analgesia and a bit of sedation, and I prep the neck really nicely, and I feel my landmarks, and I go in there, and I'm pushing this block in, and the block goes in really nicely, and while I'm pushing the last bit from the syringe, the patient says to me, Doctor, how does it work? Do the nerves from one side of the body cross to the other side of the brain? And I'm like, yes, a lot of people don't know that. Corpus callosum, they actually cross to the other. And as I'm explaining neuroanatomy to the patient, I realize I've just blocked the wrong arm. But my muck-up doesn't end there. I have such pride about the fact that I'm going to do this really high-quality block, and I've been talking up how good my blocks are, that I quickly rush around and block the other side too, so they can operate. Completely forgetting the fact that doing that has got a very high likelihood of causing bilateral phrenic nerve blocks, and the patient won't be able to breathe. Which reminds me of a story. When I started out as an intern, I was also at the good old Geef Joost Hospital. How many people in the room are the people they are today because of Geef Joost? I mean, yeah. Right, yeah, lots of hands. And so I was on call, a nice normal call, and Joost, I probably saw 50 or 60 patients in the ED, and
In about 3 minutes.
in about 3 minutes, says Kat. And I was admitting for surgery, and this woman came in, and she was this quite elderly ducky. She must have been about 65, maybe 70, fairly frail. Came in with this grumbly history of abdominal pain and a bit of a fever, but not really now, and not passing stool, and tender abdomen, but not peritonitic, and no real focus of the pain, and there was a vague history of some kind of PV discharge. We really weren't sure what was going on with her. And while I was taking her history, and I asked her all the usual questions, I was drawing my genogram and that kind of thing. And I said, look, are you allergic to anything? She said, yes, my dear, I'm allergic to penicillin. And I'm like, oh, yeah, everyone's allergic to penicillin. So what happens if you have penicillin? She said, I don't really remember, because last time I had it, my face swelled up, and then I couldn't breathe, and then when I woke up, they told me I was allergic. I was like, okay. So I wrote on my notes, patient's allergic to penicillin. Yeah, I saw the patient was a bit undifferentiated what was going on. We sent her for x-rays, sent her for ultrasound, admitted her to the ward, we'll see her on the ward round, etc., etc. And then I went on with the other 50 or 60 patients. Next morning we got onto the post-intake ward round, we're going around, we saw this lady, the consultant felt her belly, the reg felt her belly, the other MO felt her belly, nobody really knew what was going on. Consultant said to me, you know what, I'm not sure, let's put her on triples, we'll wait to get a follow-up ultrasound. I was like, okay, cool, boarded the triples, put the chart down, finished the ward round. It was about 10 a.m., got in my car, drove home, got out of my car, exhausted, climbed in the shower, and I was about somewhere washing the shampoo out of my hair when I realized what I'd done. Did you realize what I did? I prescribed this patient who I knew had a penicillin allergy. Penicillin. Back then, triples was penicillin and other things. I remember getting out of the shower, I can't remember if I turned off the tap, going through naked into my kitchen to where my phone was plugged into charge, picking up my phone, struggling to get the phone to dial because my hands were wet, phoning the ward, swearing loudly why the fuckers in the ward would not answer the fucking telephone for once in their life. Swearing that from this day forth I will always answer the telephone when it rings. Getting through eventually to one of the nurses, and I said, my dear, I need you to do me a favor immediately. I've made a mistake. I have prescribed a patient penicillin. She's allergic to penicillin. Could you please go and cancel that prescription? Tear up the chart if necessary. I'll come and fix it. She said, oh, don't worry, doctor. It's not a problem. She died about an hour ago. So, I've got goosebumps. So just think for a moment. How are you feeling right now, knowing that I almost certainly killed somebody quite as deliberately as if I put a gun to their head and pulled the trigger? How does it make you feel knowing that happened to me? Do you feel a bit sorry for me? Just think about if that was you right now. Because I know that standing naked, dripping in my kitchen and getting quite cold and getting goosebumps, I knew in that moment that I probably would not practice medicine again. That I had deliberately caused the death, well, not deliberately, but I had, through active deed, caused the death of somebody through a stupid, stupid mistake. Right then and there, I knew I was probably going to land up in court. I was never going to be able to live with myself, and I was going to have to go and become a dive instructor. I'd probably never practice medicine again. I'd probably never have the chance to heal a lot of patients, never have the chance to influence people, never have the chance to create learning opportunities, never have the chance to get involved in foam, not that we even had an idea what foam might be back then. And I was pretty convinced that I killed that patient. I got in my car, I drove to the hospital, I went to go and face the music. Turns out that patient never got a dose of her triple antibiotics. The ward was short-staffed. By the time they came to see her to give her the drugs, she had already passed away peacefully in her bed. No one had noticed her die. She didn't get those antibiotics. I didn't kill her. I'm here today. I'm practicing medicine. But I'm trying to learn from my mistakes. I'm trying every time that I hear that a patient has got an allergy or a suspected allergy to write it in the notes, turn the chart over, write it on the prescription chart, turn the chart over, write it on the anesthetic chart where we give the drugs, write it on the outside of the folder, talk to them about getting a medical alert bracelet. I'm thinking about those 2 patients who I gave overdoses to. The man with his ketamine went to ICU, woke up the next day, said, "What was that you gave me? It was fantastic." And I swore I would never make that stupid mistake again. I then went and made it again in a little child who got chest wall rigidity. And fortunately, because someone had told me about being prepared and about drawing up drugs and about having a system, when that chest wall rigidity happened, I had a syringe full of sucks within arm's reach. I was able to give it in time to release the chest wall rigidity, to oxygenate the patient, and the patient did fine. And then had a tramline anesthetic. Fortunately, the surgery went on for 4 hours, so the fentanyl had worn off by the time we woke the child up, and the child was very comfortable. I think of that patient where I blocked both arms, who fortunately did not get a phrenic nerve palsy, who went to the ward afterwards, nicely sedated, and when I went to go and see him, said to me, "Hey doctor, we had such a nice chat beforehand. You made a stupid mess up, blocking the wrong side, didn't you?" And I looked him in the eye and I said to him the only thing that I could say, I said, "Yes, I'm really sorry. I got distracted by which side we were working. We do all the things this side, and I'm really, really sorry." He said, "It's all right. I've got no pain. I'm actually quite happy, but you need to do one thing for me to make it right." I said, "What?" He said, "Please scratch my nose." And I think about that little old lady, or the little ducky at Somerset. Oh, she was such a darling. When she desaturated, I managed to grab an LMA, an old LMA, and fold it flat and squeeze it into her mouth and get it in. And I was able to oxygenate her and we could carry on with the procedure. And right at the end of the procedure, I thought very carefully, I'm going to wake her up gently. She won't even know what's happened. And so I was gently turning down my anesthetics. And about 10 minutes before she was supposed to wake up, she woke up, she went, pulled the LMA out, and her one remaining tooth went, clink, clink. And I had to go outside to her family, and because of course, it's Indian family, the whole family, all the aunties, all standing outside. Operation went very well. There was a little problem, but it was okay. But unfortunately, when she woke up, she pulled the thing out herself, and that one tooth, I'm afraid it came out, and I've looked at it, and I looked at this tooth, and I've looked at it, and unfortunately, I don't think it's going to be all right to put it back in again. And there was this deathly silence. Then her son looked at me and said, "Oh, thank you, doctor. That tooth has been bothering him so much." So, ladies and gentlemen, my mistakes are your free lessons, right? Douglas Adams said, humans are unique amongst animals in their ability to learn from the mistakes of others, and even more special in their apparent disinclination to do so. Get over your disinclination here, today, and now. Own your mistakes, learn the lessons that come from them, and hopefully we'll all be better doctors. Plus, you don't have to come to me for an anesthetic. Thank you very much.